So we're going to be talking about kidney stones today. This is going to be really a practical talk about, clinically, how do we manage these things. This is not going to be academically based. I was talking beforehand. I am not a formal person, so feel free to interrupt me, ask questions. We're here for your education and for you to get as much as you can out of this talk. So the take-home points that you're going to want to know. So one, all stones are not created equal. Just because someone has a kidney stone, that patient can look very, very, very different depending upon the patient and the clinical circumstances. The acuity of that stone matters. Is that emergent? Is that urgent? Is that elective? Is that inconsequential? When we're dealing with someone who's in an acute situation, it's because they are obstructed. It is because you have a stone that is causing symptoms, blocking the system from draining. And the key there is decompression. And decompression is going to allow for relief of symptoms and improvement. There are multiple different modalities to treat kidney stones. We're going to talk about, really kind of the big four, the most commonly used. That's trial of passage, ESWL, extracorporeal shockwave lithotripsy, ureteroscopy, and PCNL, percutaneous nephrolithotomy. And then we're going to go through some cases at the end. This is, by all means, especially during those, interrupt me, present your own cases. It's the, what would you do? What do we need to do in this situation? So kidney stones are not created equal. There are some that are completely harmless and, inconsequential and need nothing done. And there are some which, if are left untreated, will be lethal. And even if they are treated, can become lethal. So it's very important to triage these patients. So, it's kind of a stepwise fashion from, they can be clinically insignificant to mildly symptomatic to heavily symptomatic to emergently symptomatic, prompting emergent management. So why is this important? So kidney stones affect 1 in 11 people in the United States. And of those lucky 1 in 11, 50% experience another stone within 10 years for the first recurrence. So that recurrence rate is pretty high despite us giving them recommendations of trying to, prevent recurrence. Slightly more common in men than women. And then if you look at the, things that increase your risk of getting kidney stone, obesity, hypertension, diabetes, and all of those comorbidities are on the rise in the United States, which is then going to continue to raise the incidence of stones in the U.S. as well. So when you're evaluating this patient, you may be evaluating this patient in a variety of settings. Are you seeing them in the office? Are you seeing them in the ER? Are you seeing them in the urgent care? Where is this patient presenting? And there's sort of, you can't forget the fundamentals. Take vital signs. I mean, it's important. I mean, are they febrile? Are they tachycardic? Are they hypertensive? Are they tachypnic? Do they look sick? Take your appropriate history. Assess their pain. What is the severity? Is it controlled? Is it uncontrolled? It's like, yeah, doc, I hurt like crazy, but I take an ibuprofen, everything feels perfectly fine. What are their associated symptoms? Most commonly nausea, vomiting, which you're going to see associated with pain. Can that be controlled, with outpatient medication? Now, do they have fevers? Do they have chills? Do they have signs of a systemic illness? Are they feeling incredibly ill? That's going to change what you're going to do and how you're going to take care of that patient. Are they just presenting because, man, it hurts? Or are they presenting, man, I am sick? When you evaluate them, there's important things that you need to look into. So labs, complete blood count is important. And we're really looking here is for a white blood cell count. Is that high? Is that low? You can see white blood cell counts that have gone up just simply because of stress response. So someone comes in and they're looking, perfectly fine, but they have a white blood cell count of 17, but like everything else looks great. Well, they may not be septic. That term gets thrown around a lot. Their white blood cell count could be up just because they're having this stress response to this intense pain that they're experiencing. Complete metabolic panel. Now, not CMP, not BMP. Reasoning for this is that you're trying to look for anything else that could be going on. If they're having right upper quadrant pain, is it, do they have a kidney stone or do they have liver dysfunction? From our standpoint, what we're looking for is there renal dysfunction? Do you have a baseline creatinine? Do you have a baseline GFR? And where do they stand today? Do they have acute renal insufficiency? Now, One of the sort of subtleties in this is, do they have acute renal insufficiency because they have a stone that's blocking their kidney from draining, or do they have acute renal insufficiency because they haven't taken any fluids and they're dehydrated and they've been vomiting all night? A urinalysis is important. Is there any evidence of an infection? Is there any evidence of blood? And then a pregnancy test, typically in women of childbearing age, but feel free to get it in anybody. You don't really know who's pregnant nowadays. Now, imaging. The most definitive test that you're going to get is a CT stone protocol. That's going to tell you, how many stones there are, where they're located, how big they are, if it's blocking the kidney from draining, and it's going to pick up any other intra-abdominal pathology. A KUB is a great screening test, but you're going to miss a fair number of stones, especially small ones. Now, what you should know is that the size of a stone is not proportional to the symptoms that someone can experience. You could have someone with a gigantic stone and be completely asymptomatic, or you have someone with a tiny stone which is obstructing their kidney, and they can be completely miserable. So when we're talking about emergent intervention, when it's like, my goodness, this person needs something done right now, let's call in the call team, let's get this done immediately. That's an obstructing stone with a concurrent systemic infection causing septic shock. It's typically not subtle when you see it, but it's important to know that the only way to help them on the road to recovery is to get that system decompressed. These are the people who present tachycardic, they're hypotensive, they're febrile, they have an elevated white blood cell count. Oftentimes they have mental status changes. These people present because they're sick. A lot of times they may not even complain of pain. They just look ill. To treat them, initially you want broad spectrum antibiotics. Before you're going to take them to the OR, before you're going to decompress them, you want them on broad spectrum antibiotics that's going to cover everything. Aggressive fluid support, correct their hypotension. They may need pressors. And then they need to be emergently decompressed. And whether that's via ureteral stent, going up from below, or a nephrostomy tube going in from above. As to which one is chosen depends on a variety of clinical circumstances. Most folks opt for a ureteral stent if at all possible, but some people are so sick they can't undergo a general anesthetic and they just need a perc tube to get the system decompressed. Oftentimes these folks need ICU care, both before and after the procedure, and then we would delay the treatment of the stone to an elective setting in the future. So you want to make sure that the infection is cleared, and typically it's 2 weeks of antibiotics, then we'll go take care of the stone, depending upon how they've recovered clinically. Urgent intervention. These are people who have severe symptoms but aren't life-threatening. They have an obstructing stone, they have intractable pain, they have nausea, they have vomiting, they have severe renal dysfunction, they have an obstructed solitary kidney. These folks need something done. And need something done quickly, and they shouldn't be waited on. But you don't have to drop everything you're doing, bump all of your cases, and say this person's going right now because they're going to die if we don't do something right away. Elective intervention. So this is any stone. Your pain's controlled, there's no significant hemodynamic renal compromise. Folks come in with asymptomatic stones, that are non-obstructing up in their kidney. And the way I phrase it to them is, it's the difference between preventative maintenance and fix it if it breaks. If you have a stone up in the kidney, in your 30s and it's not causing a problem, at some point in your life, there's a likelihood that stone is going to drop, it's going to block your kidney from draining, it's going to become symptomatic. So you can fix it at that point when it breaks, but you're not in control of when those symptoms will happen.